All right, excellent job, everyone. And now on to just as an important debate.
So our next discussion, Dr. DeBacker is going to take the stage at the podium directly for the proposition here that that pMCS devices do not offer a mortality benefit in shock. So why are we still using them?
Okay, so that's the old presentation, but nevertheless, I will do with this one. There is an updated somewhere on the web. So if we begin our session here, it's quite interesting to realize that, well, Marwan gave me a very difficult task because we have 16 talks in this conference discussing mechanical support. So I guess that your decision is already made. Nevertheless, I will make myself the advocate of the devil and perhaps put yourself not in the shoes of a doctor treating a patient in front of his eyes and taking his memories, the last patient that indeed survived and was knocking at the door with flowers and with some chocolates because we're in Belgium. So indeed, also put yourself in the feet of a lawyer, of a patient who died under mechanical support, or maybe insurance CEO who has to pay for all these devices. So what are the data supporting the use of these mechanical support? Well, we have indeed these kind of registries telling us there are so many survivors, and at the end, yes, the survival rate is not so bad in these patients with severe cardiac shock treated with the ECMO in these conditions. If we look at the randomized trials, well, the issue is maybe less promising because indeed we have the first trials that was indeed showing no real benefit. Of course, we may admit that there was a lot of crossover in the control arm also in this condition. And then, of course, we have the ECF shock trial, which is indeed showing absolutely no difference here. And of course, if we do meta-analysis there, we see absolutely no difference at the end. So many factors may, of course, be related to that, but we may discuss whether, of course, other devices offer benefit, and then, yes, we have. We have this data here showing some marvelous benefit here that you can see here, very significant, very nice results. And so I will not criticize at all the quality of the trial itself, but we need still to make this trial into some perspective and to try to better address the relevance of the results and how this can be really translated into our clinical practice. The first aspect is that, well, when you jump into this strategy, it's not just putting one device, it's also buying all the things that go beyond it. And when you have to realize one patient every 6 patients had to go under ECMO when the patient was still under Impella CP. So it is not really the magic bullet. We have indeed still one patient every 6 patients in this very selected population that will not respond adequately to the therapy. And of course, the conservative arm was also treated with some devices that, oh yes, was often Impella also. So maybe Impella versus Impella, not always that good also. Okay, and then something very surprising. Usually when you go to the electronic supplement, you see indeed the per protocol analysis. And often the results are even more important, more difference between the two groups when you go in that per protocol analysis. Here, the reverse. As treated group, as treated, so what you will do at bedside, there was no significant difference here. So this shows the frailty of the trial because it should have been confirmed and even further emphasized and just the reverse that we see here. So also if we go to meta-analysis, of course we have for the non-unloading strategies, we can see that indeed there is no beneficial effect here. However, if we go for the unloading devices, and we do not forget the prior trials using Impella, well, in these conditions, there is no significant improvement there with the Impella. So this begins to be a bit more frightening. So we may have a problem. And especially we may have a problem when we look at what were really the patient included there. And this is a very interesting aspect, because this is a trial that was done in Germany. It's a registry in Germany of all Impellas that were implanted. And you can see here that there was no benefit with Impella. The mortality was identical to no Impella there. So, well, why do we observe this? And what was interesting there is that when we realized what was really occurring here is the fact that, yes, the danger shock was in Denmark, but also in Germany, the northern of Germany. So the German registry is going on the same time, covering the same type of geographical patients. And interestingly, there were 36 patients per year included in danger shock, while in real life, in the 2 years there, in Germany, 1,350 patients per year. So how many patients more are treated in real life than the patient included in the trial? And the worrisome aspect is that the mortality in the registry is very close to the control arm of the danger shock trial. So is this because we have some major selection there that we have this, or is it because we have other factors that maybe perhaps make this difference more obvious in the danger shock than in the real life? So we need to be cautious, because what is exactly the real benefits that we have with this device when we can see this kind of aspect here. So at the end, and I will conclude here, we need really to be very cautious. And at this stage, the literature is not so straightforward. And probably we can at some point say that, well, the limited is probably limited in some restrictive population, again, 36 patients per year in some areas, so very far from what we are doing at the bedside nowadays, and where indeed we apply the same device in some conditions that may perhaps not be representative of what was in the trial. So maybe what we do at the bedside is not really supported by the data that are published. And with this, I thank you for attention.
All right. Thank you very much. And for the con, Dr. Thukral from San Antonio is going to tell us why we should not stop using